Morning. Okay. I'm just going to go ahead and mute and just keep, if you've just joined, make sure you put in the chat that you're here. Some new people have joined, so just go ahead and put here. One thing I do want to mention is I made progress. I got some videos converted last night. So yeah, now this is recording and it's so awkward to look at myself back. But I had worked on a couple anatomy ones because they had a test. So when I'm done with our talk, I'm going to try to get all of these for this section converted onto YouTube and figure out how to get you guys the link. So at least I've got the videos starting to be converted and uploaded. So if you've had trouble hearing me or, you know, getting into the chat, we can do that. So I will work on that some today, and we'll just pick up where I left off if you don't have any questions. So hopefully you can see this PowerPoint. So when we were talking about the stifle, and if we have issues with the stifle, especially rupturing a ligament, most often is the anterior ligament, there's a couple different treatments that we can do, and they usually go by extracapsular or intracapsular. And that means, are we in the joint capsule or outside the joint capsule? So there's different techniques to stabilize. Extracapsular, obviously we're going to do some type of technique that is going to stabilize the bones, but not go within the joint itself. And then if we're going to do intracapsular, we can use a synthetic graft. And what we mean is that we're going to have to create or put in a ligament. Normally we don't sew the ligament back together. That doesn't work. So we have to do something else to mimic or try to provide the stability to the joint that the ligament would do. One thing that extracapsular, or you can consider, most people call it extracapsular. It's extra articular, meaning articular is the joint surface. So if we're we're outside of it. This is usually less than 15 kilograms, which is about 30 pounds. So that's the key here, is that these are smaller patients. Now, most of our cruciate ruptures are on the bigger guys, Labradors, Retrievers, Boxers even. But occasionally you're going to have a smaller dog that this is going to happen to. What they do is they'll go in and they're going to take out that damaged ligament. So they'll try to cut away what is torn. And then they're going to do a suture around. Now the fibula, if you remember, fibula is the sesamoid bone, and it's at the caudal portion. The patella is in the front. The fibula would be behind. Now, normally the fibula, we don't talk about very much because it doesn't commonly get injured, but this technique is we will wrap suture around those bones, those fibula, and we'll put a tunnel into the tibial crest. And then the joint capsule and the muscle fascia are imbricated, which means they're going to kind of pull those together, and that's going to cause a tightness to the joint. I think on this picture, so right now, this is the femur. So this would be going down. That would be going down towards the foot. This is going up the femur. If we look inside, there is the torn ligament, okay? Now, what's happened in this picture is they've pulled the patella off and moved it to the side. So the patella is over here. And remember, the patella is embedded in that tendon and tissue. So it's not like there's this floating bone that's going to pop out. It's all held together. And what they've done is, you can see here, is they've moved the femur over, and you can see the torn ligament. What they do here, this is showing, okay, there's the cruciate that would be intact. You've got the suture that goes around those bones. comes down, then they're going to drill holes. This is the tibial crest. Remember that that angle on the front of the tibia is the crest. And they're going to take this suture and tie it around. And they're now going to tie that together. And it almost looks like this is probably a better picture. Now, if you can look at this and imagine if this was a 100-pound dog, how this would probably not work. I have seen them push, I've seen some surgeons push the limit on a little bit bigger dog, a little bit over 30 pounds. This is definitely a cheaper surgery. If someone absolutely could not afford the other surgeries, but the problem is if you're going to pay for this in any form, it has to have some degree of success. You don't, so definitely maybe a 40, 50 pound guy, you might push the limit, but for the most part, this has to be done on the smaller dogs. And it's kind of called a suture imbrication technique. And when I say suture, some of you guys haven't been in surgery, you haven't had surgical nursing yet. This is a very thick suture. If you think of suture they use during a spay and neuter, and it's really thin, this suture we use is like a number 5 size, okay? When we do a spay and neuter, we use 2/0, 3/0 suture, which is smaller. This is number 5, and so it's a very thick suture. It's a special technique used for this kind of surgery. So this is the suture imbrication. This is extracapsular because you're going around the joint. You're not going through the joint for this surgery. This is the one I talked about, I started to mention yesterday, which is called a TPLO. Now, a lot of people get confused. When I talked about hip dysplasia, I talked about TPO. That's a triple pelvic osteotomy for hip dysplasia. This is a TPLO, tibial plateau leveling osteotomy. I do want you to know what those stand for and when you use which surgery. So what they're doing is they're going to change the angle of the joint. And what you're trying to do is we're trying to lessen that cranial tibial thrust. And what they're trying to do is eliminate the need for the cranial cruciate ligament. Because what they're going to do is they're going to change the angle. When it says steep learning curve, this surgery, okay, let me back up. If you're just bopping in, make sure you put here because my number went up, so make sure you say you're here. The last surgery I talked about, you could probably have, there's surgeons that are not, or there's DVMs that are not surgeons. They could do that surgery. So sometimes regular practices could do that suture technique. This surgery needs to do by board certified surgeons. There is special plates, drills, saws, screws. It's a lot of equipment, and there's a science to measuring the angle, and they have to cut the bone. They're basically not going to cut into the tibia, and that's just not willy-nilly. When we do this surgery, this is active large breed dogs, giant breeds, or dogs that have a very large tibial angle. So if they do the x-rays and they see a large tibial angle, they may consider, you can do this on a 30, 40 pound dog, no problem. But this is the technique you're gonna do if you've got a big guy. Great Dane, Labrador, 80, 90, 140. We've done this on 150 pound Rottweilers. And this is probably the #1 surgery we did when I was at Northwood and when I was at VCA. This kind of came after I was at Purdue. So this surgery, not that I would say it's newer. It's been around a while. But this is probably the #1 surgery we would do. And I'm going to tell you, this surgery is about $3,300 to $3,500 per knee. If you look at this picture, okay, if you can see this tibia angle, they will take x-rays and the doctor has software and they will measure, they can put these lines in the computer on their software. They measure the angle and they decide how they're going to make the cut. And if you look at what they've done is by cutting this portion of the tibia, so they do a saw through here, and they do that by measurement, and then they're going to rotate this part of the tibia, and then they're going to put a plate here. By doing that, it's going to change the tension on that patellar tendon and ligament, and that's going to give the stability to the joint. So again, this is done outside of the joint. So this is still extracapsular because they're working with the tibia. Now, they will probably go into the joint and clean it up. Clean up the meniscus, remove the tear or remove the tissue, and then go ahead and do this. And here's some other x-rays. So you can see right here, that's the femur. Up there is the patella. Here is the tibia. And what they've done is they've made a cut here and they've pulled that, and that's going to change the tension and change the stability of the joint. And this is what the plate looks like. Here they've put it on a model. So you can see this is a special TPLO plate. So there's bones and screws. They change the angle, gives you the tension. I will say when you do this surgery, the goal is that plate stays in. So normally that's going to be with them. There are cases where sometimes, well, let me get into the next slide, that sometimes anytime you do a surgery like that, anytime you put a plate in, you have the chance for infection to set in. So we have to be very strict with aseptic technique, very sterile. We give the patient IV antibiotics during surgery. Sometimes they might go home on antibiotics. I will tell you, we've had dogs come in for this surgery, and then we'll look at their belly and they have like a pyoderma, or they have a rash, or their skin looks really inflamed. We'll send them home for a week or two on antibiotics and have them come back, because if they have any sign of a skin infection before surgery, we're not going to, this is cutting into the bone. And anytime you cut into the bone, if you get infection in that medullary cavity, it can destroy the bone. So the key thing here is making sure that we have good technique, that we try to prevent infection. A big thing is these dogs licking after surgery. I've seen infection seep in because the owner didn't put the e-collar on. Sutures got loosened up. We create an infection, and that seeps into the surgery site. So e-collar, e-collar, e-collar. I tell owners, I said, unless you want to spend another $1,500 coming in and treating a bone infection and a second surgery, and usually when I tell them that, they leave the e-collar on. I'm like, 2-3 weeks of an e-collar or $1,500 in a second surgery. Potentially up to $3,000 if we have to repeat. I mean, so I'm very strict about that. I've seen them screw up just because owners were too lazy or decided they felt sorry for their dog and wearing an e-collar. Well, I'm sorry, if I just spend $3,500 to do something, I'm going to make sure it works. Okay. So, make sure that's our job as a tech, to go through all those instructions. Implants can always fail. So sometimes those screws could loosen up. You can get arthritis. I will say I occasionally have seen these cases come back where the dog was fine for a year, and then all of a sudden the dog starts limping on that leg, and the leg is a little red over the stifle, and that can be a late plate or implant malfunction where they somehow got a late infection. That's rare, but it does happen. But I always tell owners, the minute your dog becomes lame again, you need to let us know, because that's a sign that maybe something's wrong with the implant. As far as post-op care, and I do want you guys to be familiar with this, because this kind of goes with almost every stifle surgery. Okay, this is very strict for TPLOs, but anytime you do a stifle surgery, they are pretty much restricted for 8 weeks. The first 4, absolutely. They should go outside to go to the bathroom, and they should come back in. And typically when they're in the house, they're somewhat confined. We don't want them running upstairs or running around the couch and chasing a dog or, catching the ball. It's pretty much outside, inside, potty only. Um, I think this is important to understand. My neighbor, and when her Malamute had this surgery, and um, it was like week 3, and I'm looking across the street and I see her taking her Malamute. We have a big walking path, and she goes walking, and I start looking at my watch, and it's like a half an hour later she comes back. And I said, "Where'd you go?" Because she was always calling me for advice. "Oh, my dog, blah, 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 blah." And she goes, "Oh, well, she wanted to go for a walk." And I go, "You're not supposed to be taking her." "Oh, no, but she wanted to go. She's fine. I said, "She's feeling better because she's healing." And then sure enough, the very next day, she's limping. She's febrile. And she goes, "Oh, I probably shouldn't have taken her on that walk." I'm like, "You think?" So, the dogs, that's the problem with dogs. The minute they feel good, they are not going to limit themselves. And so, being a surgery tech, I had to hammer this into people. I said, I don't care how good your dog looks. I don't care how much he wants to play. Do not do it. You just spent $3,500. Don't do it. Okay. So 8 weeks strict confinement. Usually we do some cold packs. A lot of times we'll go through and we'll do some cold, some heat. Cold is going to help reduce the swelling because they are going to be swollen after surgery. We just cut into their bone. So there's swelling. ROM is range of motion. Let me type this out. So normally what we'll do is when they're laying down, I say, like, you can bend their hock. Now this is not putting them on a treadmill. The dog is not on their leg. And I will do like passive movements. I'm not hyperextending the leg. It's just kind of moving their hock, rubbing around the stifle, trying to stretch the leg because, they're not going to be putting a lot of weight. Everything is also leash walking. Any stairs, if they have to do stairs, they should be supervised and controlled. Usually we'll send them with a sling because in case they lose their balance, we don't want them falling on that leg. So normally I tell owners, sling them outside, sling them upstairs so they're not putting weight on the leg. And where they're confined, no slick surfaces. A good technique for any knee surgery or any dog having problems is just go to like the dollar store, Walmart, and get some of those cheap bath mats. They've got that sticky on the back, and you can put those rugs throughout, especially if you have hardwood floors, linoleum, and that way they don't inadvertently slip, because if they do, they can damage the implant, damage the leg. Normally, you're going to increase activity over time. Normally, everything in that 8 weeks is pretty confined, but normally at 4 weeks, we told them they can start, making the walk a little bit longer, maybe taking them out a little bit more often. Nothing crazy, but weeks 4 to 8, we slowly started to increase. And one thing I want to let you guys know, whether you're going to be doing surgery or not, the key that I always told owners was, if your dog comes in and they're not weight bearing, okay, we do surgery. The first week or 2, they're probably still going to be holding up their leg because people are like, he's still not using his leg. I'm like, we just did surgery. He's not going to use his leg yet. But gradually you should start to see toe tapping. And then weeks 2 and 3, they start to put their paw down, and then it progresses to complete weight bearing. If at any point the animal starts holding up the leg again and starts toe tapping, that's a sign there's a problem. So it should progress to full weight bearing within that 8 weeks. If at any point they were weight bearing and they go back to that flamingo stance or excessive toe tapping, they need to get looked at. Okay. they're going to be on non-steroidals. This causes inflammation in the joint, in the tissues. Anti-inflammatories treat pain. They're probably going to be on like gabapentin and tramadol, but definitely non-steroidals. And then some form of weight control. Now, not every dog that comes in for this surgery is overweight, but if they are a little heavy, you need to talk to them about, maybe starting a diet plan. And then when the dog is back to normal, potentially doing some activities. And when this dog is healed, when we release them at 8 weeks, we usually recheck x-rays. So at 8 weeks, they usually come back in and we take an x-ray and we look at how the bone has healed. There will be a point, probably closer to 12 to 16 weeks, where the dog is released to full activity. And at that point, the owner might want to ramp up exercise. Obviously, there's a lot of physical therapy now. We have we had a student go on externship and she was doing a surgery physical therapy externship at Purdue. And that field for you guys, if you're interested, is really increasing. So there's definitely, water treadmill. Most of our TPLOs after surgery are offered a rehab package at VCA. So you can either give the owner home rehab exercises, or you can offer to come in for rehab with the water treadmill. They'll do massage, they'll do range of motion, or I would teach the client on discharge how to do it. So those are options that are available. So do you have any questions? If you have any questions, you can type it in. Let me get into now patella luxation. This is a different issue. Let me just bop to the slide for a second. Okay, in a normal stifle, here's the femur tibia. There is a groove, there is a divot in the femur, in the distal femur. The patella should sit in that groove very tightly. This patellar tendon, which is attached to the quadriceps up here, it is, and then it's attached to the tibial tuberosity, is supposed to have a certain tension. And when the knee moves, that patella is supposed to stay in that groove. When we talk about luxating is something coming out of place. So that it means the patella is moving out of that groove. And that is the issue. If it can move side to side, that's going to become a problem. So let me go back here. If you bend the stifle and you change it, if it may pop out of that spot. Now, this is a small dog issue. This is often your little poodle, Pomeranian, pug. They got those short little legs. We see this a lot more in small dogs. Any dog can luxate a patella, but if it's going to be a bigger dog, sometimes it happens during trauma. It's not as common with the larger breed dogs. Now, small dogs may luxate more in. There's a lot of dogs where it's bilateral, meaning both patellas are affected. And you can feel them both pop out equally. And a lot of times this is just genetics. Due to their makeup, due to their bones, they just have this problem. And sometimes the large dogs tend to luxate on the outside, the little guys tend to luxate on the inside, but they may walk, these guys may bunny hop, or they may be trying to walk more forward, and it may seem like their legs are bowed. So sometimes you see this in this. There are some larger breeds that it can happen to, but I want you to know it's the small guys. So here's the normal orientation. Here are two slides where you can see where the patella has popped out of place, okay? And if you can imagine that if the muscles, if the stifle changes position, it changes the tension of that tendon, of that patella, and it can actually come out of place. MPL, medial patellar ligament. Did you get that? Okay. Okay, so now when we feel this, I will tell you this, the first time I felt that and holding a dog in high school, and of course I know nothing, I'm just in high school, I'm holding this little dog in lateral recumbency and it starts to struggle and I feel this awful pop and I think I broke the leg and I'm like freaking out. And then my boss is like feeling the legs. He's like, oh, this dog just has luxating patellas. And the owner knew and she didn't want to do anything about it. The dog got around fine. I mean, the dog had some significant arthritis and it's going to have problems later, but they all knew. I had never felt that. And it feels very eerie when you're holding their back legs and you feel this pop. You almost feels like you broke the leg, which is hard to do, but you got to be careful. We give these grades. Oh, not medial patella ligament. I'm stupid. Oh, I got that on video, dang it. Medial patellar luxation. Sorry, not ligament luxation. I need more coffee. Did you get that, Caitlin? Sorry. Okay, we give this 4 grades. If you remember me talking in anatomy when I talked about grading heart murmurs, we also grade patellar ligaments. Now they go grade 1 to grade 4. Grade 1 is you are holding the dog and the doctor can manually push it out, but it will go back in on its own. So like if the doctor kind of pushes it out momentarily, the dog stands up, the patella comes back into place on its own. If it's a grade 2, it's going to move out of that groove, but then it can be manipulated or pushed back in. So grade 1 and 2, now a grade 1 dog can probably live its life with that patella just like it is. When we get into grade 2 and up, it's going to probably usually recommend surgical intervention. If it's a grade 3, it rides out of its groove most of the time, but it can be replaced by using manipulation. Okay. And grade 4 is it rides out of the groove all the time. Grade 4 is the most severe. And if you try to pop that stifle or if you try to pop that patella back in, it's not going to stay. It just basically rides out. Now, let me go back. Now, if you go to this website, the acvs.org, that's the veterinary surgeon's website, it has a lot of good information about this condition and surgery. Let me go back to this picture. If you can imagine, when you get into grades 2 and higher, 3 and 4, the more that patella goes back and forth, that's bone moving against this bone. And what it does is it starts to erode that groove. And it causes inflammation and it causes problems with the joint. So the more severe the grade, the higher the risk is of pretty severe arthritis as they get older, because that's just going back and forth and rubbing on that distal femur. Now, how do we diagnose it? Well, these dogs sometimes come in where they're holding their leg up. Sometimes they kick it out back and shake it. They're trying to pop it back in. So sometimes the dog itself will try to they might move their leg strangely or extend it, and they're literally manipulating their own leg, especially for those that pop in and pop out on its own. Sometimes the owners will say, well, occasionally he limped and now his limping's getting worse, because what's going to happen, it's going to start getting worse and causing more inflammation. So that's what progressive lameness is. Obviously, the number one way to treat or to diagnose this is going to be a radiograph. You're going to take x-rays and you're going to see that patella out of place and then palpate it. Now, Palpation is just feeling and the doctor trying to put that back in, just moving it back and forth. This one you can usually do awake. I talked about the hip and hip dysplasia. Quite often you need to do that with sedation. Now, if this dog is really painful, you might want some sedation, but a lot of times you can do this exam awake. The radiographs you could potentially do awake. You're gonna get better x-rays if they're sedated. But a lot of times this is fairly quick to diagnose. And if they have the bow leg, if their legs look kind of like they're bowed, that's typically the medial patellar luxation. And then if their knees are moved in, it's typical a lateral luxation. However they're holding their leg is usually the opposite of where the kneecap is going. So let's see. Most of the time, how we're going to treat this is to try and get the patella back in the normal position. Try to get it back to where it's going to be. The treatment is going to depend on what the grade is. So obviously grades 3 and 4 might be different than a grade 2. More often than not, these dogs will need some cage rest. So again, confinement, just like I was talking about with the other things. It's maybe not as strict as I talked about, non-steroidals, and then we're going to recommend surgery. Sometimes with these dogs, if they don't want to do surgery, we're just going to say, you know, be cautious with exercise, give them some anti-inflammatories for arthritis, get their weight under control, because sometimes these little poodles are a little portly. That's going to put more pressure on the stifle. So trying to get that weight down is definitely going to help. Anytime we're worried about a joint issue, weight management becomes huge, because the less they weigh, the less pressure there is on the joint. So that goes for a lot of diseases. Haley asked if with my dogs, is there a way to know if when she fully tears it? The only way to know if she fully tears it, she probably will become more lame or completely hold it up. It's very rare that a dog has a complete tear and it puts weight on their leg. So usually the cardinal sign of a full tear is complete lameness, where they barely are toe tapping or they're completely holding up their leg. You obviously can take her in for an exam and a doctor should be able to tell if it's fully torn, even with the medicine. I will say dogs are stoic and some dogs hide pain better than others, but if there is a complete tear, there's no stability. There's not a lot of stability in the joint. So it would be hard for her to put that complete weight on her leg all the time. The best way is to just have a periodic exam and see, but most of the time the knee is going to be more swollen if it's fully torn, and she's not going to put as much weight on it as she did before. That would be my best advice. And a physical exam by a vet. So good luck with that. Just be cautious. So one of the more advanced surgeries we can do for patellar luxation is called a tibial crest transposition. If you remember, the tibial crest is this front part of the tibia. Transposition is changing its position. And when we do that, we put different tension on that patellar tendon, okay? So if you look here, the tibial crest is elevated, reattached to the proximal tibia where it's aligned with the trochlea. The femoral trochlea is the groove where the patella sits. You're going to use a pin, and you're going to pin and create a tension band fixation. You're going to change the tension of that tendon. And hopefully this can be used for both surgeries. So if you look here, and sorry, it's a little fuzzy, is they're going to take the tibial crest and pin it and change. If I go to the next surgery, or the next slide, is basically, let's see. So what they're going to do is they're going to cut part of the tibia here. So they've made the incision. They're going to take a pin and pin part of this tendon over, and what you're doing is basically pulling it, and you're trying to pull that patella back into that groove. And by pinning it, that's going to heal and put a different type of tension. The other thing that is done is doing something that's called a wedge resection or recession. Basically, one of the issues sometimes these dogs have is this groove on the femur isn't very deep, it's very shallow, and that allows the patella to move back and forth. So what they're going to do is, if you look at here, is they're going to cut, they're going to do a wedge. There's a little saw that we use, and we literally saw into this groove, and we make that groove deeper. So hopefully the patella will sit deeper in that groove. I've seen them do it with a saw. I've seen them do it with a file. And they're going to just, but what it is you're just deepening the groove so the patella sits deeper. Some of these dogs barely have a divot, and that's their issue, is the patella can slide because it doesn't have a groove to sit in. So that's what a wedge resection actually is. So the two things that you do for the stifle is the wedge resection, tibial crest transposition, or you can literally just do medical management, which is the weight restrictions, activity restrictions, cage rest. The less they use that leg, the better it's going to feel. We're going to cause less inflammation, less issue. So post-op, with either surgery, obviously the pinning one, you've made an incision and you've put a pin in a bone. You had, like I said, the recovery is not like a TPLO. You still need to be fairly restrictive. So minimizing activity, leash walking, non-steroidals, physical therapy. That dog is not using those muscles in that leg. So that's like the massage, the range of motion. Water therapy is great. We just don't all have access to water therapy. But I'm telling you, if you have a little poodle and the sutures are out, put them in the bathtub. Try to hold them up and make them do like swimming. I mean, they're not putting weight, but they're moving their legs. So the nice thing is with the little guys, we can kind of create water therapy depending on their size. So you got a little guy, you know, you can get creative with water therapy. Physical therapy is just going to help reestablish those muscles and establish some strength. Again, some of these resources here, ACVS is probably the best site to look at because it has a lot of resources for clients. But the College of Veterinary Surgeons is going to have the most information. There's a vet specialist website on here that gives information as well. Do you have any questions? This is probably a good point, obviously, to stop. I'm going to start with the fractures tomorrow, but since you have Gillis, hang on.